I'm going to tell you, I had reason recently to review the perspective on kidney cancer and what's changed in the last 60 or 70 years. Let me just sort of remind you, in 1950, if you had metastatic kidney cancer, your likelihood of dying from that was within, your average survival was about 10 months. In 1950, metastatic kidney cancer, 10 months average median survival. And your response rate was about 5% to best therapies. In the year 2000, it was exactly the same. 50 years of metastatic kidney cancer, no progress, 50 years. And then suddenly, between 2000 and now, we've increased overall survival by 5-fold, that's 50 months, not 10 months, and we've increased response rates by 6-fold, 60% with various therapies, 60% response rates. That's remarkable. I think we're living through a time where it's almost like, you know, our predecessors with penicillin, we've seen that much change in 20 years. Half my career, that much change, and that's really an unbelievable achievement. So the question is, why is that? Is that because of what we're doing surgically, or is that because of medical oncology, or is it because of both? And that's what I'm going to try to talk to you about in the next couple of minutes. So this is just to show you the incidence is going up. We're detecting a lot more kidney cancer, but we're not bending the survival curve among white males, black males, white females, or black females. We're finding it more, we're taking it out more, and we're just starting to bend the survival curves. So it's almost like Dickens, A Tale of Two Cities, A Tale of Two Modalities, the best of times, the worst of times. Surgery for kidney cancer, and the guidelines haven't changed very much, although we've got new tools, medical on therapy for kidney cancer, lots of clinical trials, lots of approvals, it's actually 15, and a robust pipeline. So, Chapter 1, Surgical Management for Localized Kidney Cancer. What's changed? What do the guidelines tell us in the last 50 years? What do you do with this? Excise, ablate, or observe? I think we all know that we could argue, and we do argue at our meetings, if that person comes to you with a GFR of 62, that reasonable experts can disagree. Some people would say partial, robotic partial, radical, laparoscopic radical. Some people would say watchful waiting, biopsy, no biopsy. But has it fundamentally bent the curve? When I first arrived in Philadelphia from the Cleveland Clinic, I saw a couple of cases that were really sort of highlighted and sort of colored my experience. I'm going to go through with you two of them on various ends of the spectrum very quickly. 62-year-old guy walks into my clinic. He's got a small renal mass. He's a smoker, but he's 62, and he's got a bit of a low performance status, and that's his tumor. All right? 62 years old, and then I see a couple months later, a 77-year-old guy, a great performance status, with a GFR of 45, and that's his tumor. Small renal mass. What do you do? How do you make those decisions? Where do you stop? Where does the variations in care change? On the first guy, I actually booked him for surgery, but he never got cleared. He had a stroke, and he lived another 7 or 8 years with no change in his tumor and expired of other causes. 6 years later, that's that guy right there. The tumor just sat right there. That's what prompted my interest for active surveillance. But more importantly, or equally importantly, I helped that guy by doing nothing. But this guy here, I actually operated on him because his tumor was growing. I got a little worried. He got very worried because I was worried. And we operated on him. And at the end of a laparoscopic partial, with all metrics perfect, minimal blood loss, negative margins, no problems, he arrested, taken to the cath lab where he died of a stent occlusion. And so on the first person, I helped him by doing nothing. And the second person, I shortened his life by doing something. And it made me think, how do we make these decisions? And what do we need to do about the guidelines? And that's what I'm going to talk to you about, the guidelines. I co-chaired the guidelines committee for localized kidney cancer. I'm going to highlight just a couple of things that have basically changed in the last 50 years. There's not really that much, but I'll go through with you. The first thing is we need to communicate better. The answer is just not black and white. It's not binary, radical nephrectomy or no radical nephrectomy, which is what it was like when I was a resident, basically. You had your kidney out, open subcostal or retroperitoneal radical nephrectomy. The AUA wants us to assign a CKD score. For those of you, I just took my recertification exam. These things appear. They want you to check for proteinuria. So that's pretty much, it's easy for the guidelines-based evaluation. Chest x-ray is enough. Chest CT, bone scan, renal scan, PET scan, all not necessary. You could use your judgment for those things, except for PET. There is no defined role for PET. And then, of course, you've got to assess the tumor complexity. They want you to sort of make a mention of some sort of complexity score in the guidelines. And then you got to provide counsel to the patients and tell them basically that these T1A lesions have low oncologic potential. That should at least be mentioned to them. Now, most people will say, yes, but there's uncertainty. I'm not sure what that means. I'm young, I'm healthy, take it out. And I don't disagree with that, but at least they should be made aware that the natural history of these tumors within the first 2 or 3 or 4 or 5 years is probably fairly indolent. Now, CAT scans and MRIs can't tell us anything about histology, but you could look at them and get some sort of an idea that this looks like a papillary tumor and this does not look like a papillary tumor. Homogeneous, delayed uptake, delayed washout, and you've got to sort of get a complexity score. This is an easy partial. It's a bit of a trickier partial. Doesn't mean you can't do one. Doesn't mean the biology mandates you don't do one, but at least you should quantify that for the patient as well. They tell us on Statement 6 that physicians need to review the serious side effects of the urological surgeries and morbidities therein. Of course, that's what complexity score does for you. This tumor is an easy one. I would tell this patient, you've got a low nephrometry score, a low complexity score, partial nephrectomy is associated with high functional outcomes and low risks. Of course, I would tell somebody like this, as we all do differently. I tend to be more objective. Some people tend to be a little bit more subjective in their counseling. That's okay. The AUA just wants to make sure you're having that discussion. I use the ACS Calculator. If you haven't used it, it's easy. Here's the calculator website, and it tells you, and we actually present this at our M&M. What's the risk of serious complication, any complication, and length of stay predicted by the calculator? And how do we do vis-a-vis this? We're part of the NSQIP, so this is for lap nephrectomy, open nephrectomy, partial nephrectomy. We were actually named in the top 10 in the NSQIP nationally for morbidity and mortality in all high complexity cancer cases. And it's in part because we have these conversations at our M&M. The AUA guidelines say that partial nephrectomy is associated with a higher risk of urological complications. I think we know that. The data are pretty good, but the higher risk of complications are highest in the highest complexity score, and that's basically what they want you to do, communicate that risk to them, and we've published that, as have others. They want you to talk about genetic screening. 46 is the number that they say. If a person less than the age of 46 presents with a sporadic kidney cancer, get genetic counseling, or at least tell them that that's possible. And they also ask you if it's multifocal or bilateral, consider it. So that's another change. That's just because people with genetic or germline mutations tend to sort of present earlier than those without. And we know that. And I just put here, and I think it may be in one of the handouts, some of the ways that we do our genetic counseling in patients with von Hippel-Lindau, Birt-Hogg-Dubé, hereditary papillary renal cell carcinoma, hereditary leiomyoma renal cell carcinoma. All these new genes, germline mutations that have been associated with solitary kidney tumors and or increased risk. And it goes on, Cowden syndrome, SDHB-associated types, BAP1-associated types. This is confusing for those of us that don't do this every day. But in point of fact, these germline mutations are rather easy to identify. They talk about a restricted role for radical nephrectomy, a primary role for partial nephrectomy, and to emphasize the functional aspects of the disease. So obviously, very different partial nephrectomies. These are both of my patients. Both of these people had partial nephrectomies. Some of it is dependent upon your personal experience and your training. But what they say is cancer-specific survival was associated with tumor size and stage, not whether you had a partial or radical. I see a lot of patients that think that radical is more curative. In some cases, probably T3, it may be T3 venous, but in most cases it's not. Metastasis-free survival in this AHRQ report was not different between partial and radical. Patients should know that. In fact, partial nephrectomy saves more nephrons, as you can imagine. There's very good data from multiple studies on that, including a randomized trial, which may or may not translate into better overall survival. That's an argument. So I would say for cancer control, partial and radical are equal. For overall survival, we're not sure. Renal functional outcomes, of course, partial nephrectomy is associated with better renal functional outcomes. There's no doubt about it. I put this here because I tell patients, if you have a radical nephrectomy, the AUA guidelines say you lose about a third of your function. If you have a partial, you lose about 10% of your function. And I actually estimate their GFR before surgery, and then I come back to it in the follow-up and say, this is what we did for your GFR. And so radical nephrectomy or partial nephrectomy, cancer control equal, overall survival unknown, partial wins for nephron preservation, radical wins for perioperative complications. And then finally, selective use of tissue ablation for small tumors and consider active surveillance. And the AUA guidelines specifically define when to do that. So here's a 76-year-old person with that lesion. In 2004, gets cryoablated. In 2006, it looks like that, and it's gone by 2009. You can expect that in about 30% of patients. Some 70% of patients won't have full resolution of their cryoablated lesion. I think you're fairly aware of that. The guidelines in Statement 28, and this is important, says, regardless of the age, you can watch a renal mass if it's under 2 centimeters. I think that's actually a very defensive and defensible situation. I'm not suggesting that you would watch a 28-year-old person with a 1 centimeter solid renal mass, but the guidelines at least give you that ability. And I do get a lot of calls from malpractice attorneys about patients who were watched, and the question, of course, is that guidelines based? And the answer is, in these cases, yes. And then the guidelines go on to tell us about how to pick patients and how to manage patients and how to follow patients with small renal masses. I'll just show you, we've now published over 544 lesions watched. Here's a waterfall diagram. For those of you that don't follow this, if the tumors are getting larger, it's above this blue line here. Very few of them get larger faster. So we do surgery on these people, and we avoid surgery on all of these people. And when we do that, we find out that we declare that they need surgery very early, and we also find out that if you had surgery, that their probability of metastatic disease is no greater. That is to say, delayed intervention is a viable strategy. See overall survival here. Doesn't matter if you had surgery or continue to be watched, cancer-specific mortality, if you select your patients well, is actually still very low. So to finish the chapter 1, that is the surgical contribution, if you will, to the progress we've made in kidney cancer. Cancer control, excise. Overall survival, cancer control, excise, ablate, or observe. Shorter term data here, longer term data here, but probably a bit of an advantage to the young person for excision. Overall survival depends. Observe has the best nephron preservation, and complications, of course, observation. So for the elderly and the infirmed, and even for some of the younger people that have other things to get done medically, active surveillance or a period of active surveillance is adequate. So we've improved perioperative care. There's no doubt about that in the last 30 years. We've debated the role of adrenalectomy. I'll tell you that we haven't really sort of come to any conclusion as to whether or not you need to, if it's therapeutic or diagnostic. We've concluded that we've taken out too many adrenal glands. I think most people know that. We've not really changed overall survival in locally advanced kidney cancer by doing that. And so what we say now is if the patient's got normal radiographic appearance of the adrenal, regardless of where the tumor is and the size of the adrenal, the old teaching that if it's upper pole or large, you've got to take the adrenal out, you don't need to if it's radiographically negative. If it's abnormal, radiographically take it out, and there may be a benefit to taking it out if the patient's got venous involvement. I generally tend to take them out if the person's got venous involvement. What about lymphadenectomy? Routine lymphadenectomy, as you know from the EORTC study, is not necessary if they're clinically N0. So we also believe that lymphadenectomy is diagnostic, not therapeutic. We've debated the role of lymphadenectomy. We continue to debate that role in our literature. How many nodes should you take out? What's the template? How do you define, who's going to benefit from lymph node only removal if they only N positive and M0? We've not really bent the survival curve with lymphadenectomy. I think we need to be honest that this is not, probably a Hallstedian disease. This is probably something other than that. The guidelines say that you should do a lymphadenectomy for staging purposes and remove all enlarged lymph nodes if they're there, but otherwise you do not need to routinely do a lymphadenectomy. I think you're aware of that. And the data from the Mayo Clinic bear that out. Whether you've had lymphadenectomy or non-lymphadenectomy, propensity score matching showed no difference in disease-free or overall survival. So surgically, we haven't really impacted this disease so far in the advanced case with adrenalectomy or lymphadenectomy. What about adjuvant therapy? You probably know that urologists and medical oncologists have really partnered to complete a lot of adjuvant therapy trials. Over 13,000 patients enrolled in adjuvant kidney cancer trials. So far, we've not proven that it increases overall survival. So far, it has been shown, and this is just sort of a list of some of the sort of older trials. We've tried radiation, we've tried estrogens and progesterones, we've tried BCG. Actually, there was a trial in BCG for adjuvant kidney cancer. Thalidomide, an anti-angiogenic, oncophage, they were all negative. There was one sort of signal back in the early 90s on immunotherapy. But currently, we've done adjuvant sunitinib, sorafenib, pazopanib, axitinib, G250, everolimus. They're all negative, with the exception of this one study that probably most of you are aware of. It is a randomized trial. where it randomized patients to T3 disease, N-positive disease, good performance status, to either get sunitinib for a year or nothing. They had about 700 people in the trial. And they showed that although you didn't bend the survival curve by giving patients adjuvant sunitinib, they seemed to be disease-free radiographically a bit longer. So if a patient comes in and they say, and I've taken out their locally advanced kidney cancer, and they want to know what they can do to decrease the risk of recurrence, I do send them to medical oncology to talk about this, but my experience has been that most medical oncologists won't give it because of the lack of overall survival benefit and the side effects involved. The guidelines, the NCCN guidelines don't mention any use of adjuvant or neoadjuvant therapy, except to say that you can put them on a clinical trial or you can consider adjuvant sunitinib. So that's all the guidance you're going to get for perioperative systemic therapy. Instead, we've partnered to do a lot of these adjuvant immunotherapy trials. And I have to say, although this is not a talk about the biology of kidney cancer, adjuvant therapy and neoadjuvant therapy for kidney cancer probably makes the most sense. These are highly angiogenic, highly immunogenic tumors, and the best solution to the heterogeneity of those antigens is probably at this point immunotherapy. So I have to disclose I'm the PI on this trial, the atezolizumab placebo trial. This trial was fully accrued by urologists largely in combination with medical oncologists, over almost 1,000 patients that we put on this trial. The pembrolizumab trial is also fully accrued. There's an adjuvant ipi-nivo trial, and there's a couple of others. But I mean, I have to say that urologic involvement in these trials is essential. This doesn't move the needle unless you sort of send them forward. Finally, I'm going to talk about cytoreductive nephrectomy. Cytoreductive nephrectomy and its role is changed. I would say that, in years past, when you were presented with a person with a large tumor and metastatic disease, whether they had surgery first or systemic therapy first or they went to a clinical trial, we could debate it. But in the end, it very much depended on where that person went. If they saw a urologist, they may very well start with cytoreduction. If they saw a medical oncologist, they may very well start with systemic therapy. And so that's sort of a bit of variation that we probably ought not to have had. But although the data aren't definitive and each of us can defend our position, it's hard. If we had to make an argument for cytoreduction, what would that argument look like? We would probably say that cytoreduction can delete some clones, maybe the bad clones, maybe we can render them R0 surgically. Maybe we can affect the natural history by decreasing the number of sort of clones that can metastasize, perhaps improve pharmacodynamics because necrotic tumors don't absorb these agents very well. We could maybe make an argument, and this was like a chapter I wrote with Andy Novick when I was a fellow, about spontaneous regressions. I've seen maybe one, after a radical nephrectomy. It can relieve symptoms, but most of these people aren't terribly symptomatic. The truth is it's aggressive. Surgery is aggressive, and that's what patients want, and that's what surgeons do. We take things out, and they usually think of themselves viscerally as just wanting this thing removed. And so it resonates, right? But the truth of the matter is, prior to the sort of, advent of major systemic therapies, we took it out because it's all we had. Interferon was completely ineffective. So that's what we were up against. That was the bar prior, 15 years ago. But now we've got all these other options, and these options have expanded. But the only real expansion in our surgical options is we could do it at MIS, right? So that's not a game changer other than for perioperative morbidity. So what do you do, and how do you think about these patients? Surgery is still perceived as playing offense. Systemic therapy is perceived as playing defense. I think that playing offense resonates, but I think we should sort of change that conversation a little bit in light of the Carmina trial. In terms of the guidelines, the NCCN really doesn't give us much help. They say, surgically remove it if you can, and if the patient's got a good performance status. Don't remove it if the patient's got brain mets, as you probably know. And the EAU says the same thing, but the AUA doesn't say anything about cytoreduction in their guidelines. And so, we haven't really come to consensus about who's the best patient. There's no doubt there's a selection, here. We can usually tell people who are going to do well: good performance status, lung-only disease, non-visceral disease, non-hepatic, non-bone, non-brain. Those patients younger tend to tolerate the surgery and get to systemic therapy faster. But do we really change the biology of the tumor? And do we change the biology of the tumor as much as systemic therapy does? Remember, I started this conversation by saying in the last 50 years, there was 50 years of no progress, now 20 years of massive progress, right? They say sometimes decades go along and nothing changes, then moments come along and decades occur. And that's what we're in the midst of. And the question I'm trying to get to the point of is, are we changing fundamentally that biology surgically, or with medical oncology, or with both? So here's the sort of bar that we've got to jump over. In the recent sort of combined immunotherapy trials, we've got a 60%, as I alluded to before, overall response rate with axitinib and pembrolizumab. We can't deny patients the ability to take these medicines by doing a cytoreductive nephrectomy. And I will tell you, one of the strong guidelines I would have for you is, if you do not think that the patient will get onto their systemic therapy in short order, meaning weeks after your surgery, because of their performance status or their frailty, simply don't do it. Response is common with these agents. It's early, it's ongoing, survival benefits are indisputable, and probably somewhere about 15% of people, 20% never actually get onto these drugs. So be careful of that. We know that from years and years of cytoreduction nephrectomy that patients who benefit the most are the ones with the best performance status. We know that you don't benefit if you've got non-clear cell cancer. So if you're looking for a reason not to do cytoreduction, maybe get a biopsy. If it's non-clear cell, you've probably found yourself a bit of a reason. Don't do it if it's sarcomatoid. Those patients don't do very well. Very, very good Kaplan-Meier curves for that. And then there's some retrospective data to suggest that, yes, if you do select your patients well, the survival is improved. And that's probably as much of a function of selection as it is of biology. Okay. Recently, a nationwide inpatient sample showed that you could do cytoreduction in older people if the performance status is good, with reasonable perioperative complications and risks. So so how do you arbitrate sort of cytoreduction or no cytoreduction? Performance status, I think, is probably the most important thing, followed by some of the Memorial or IDMC serum markers. Hemoglobin, if they're anemic, be a little bit more cautious. If they're hypercalcemic, be a little bit more cautious. Actually, this shows up on the in-service, these Memorial Sloan Kettering criteria, and it also shows up on the recertification exam. So is it biologically significant or statistically relevant? This is the Carmina trial. You had nephrectomy and then sunitinib versus sunitinib alone. Basically, it showed that giving someone systemic therapy up front was non-inferior to doing a cytoreductive nephrectomy first. Most data suggest that you can get these patients safely to, after cytoreduction, to systemic therapy. So here's what I would say in terms of cytoreduction. There's no level 1 evidence for cytoreduction in TKI era. If you see a patient, you may want to do a biopsy. If you do that biopsy and sample the tissue and they've got a good performance status and it's clear cell and they've got no visceral metastases or brain metastases, I think cytoreduction means favorable risk. You can do well. The number of cytoreductive nephrectomies is going down. There's no doubt about that. Over the course of time, we're doing less and less of them as our systemic therapies get better and better. So, in summary, acceptable morbidity profile for cytoreduction if you pick your patients well. Most of them will go on to get systemic therapies. Don't do it for poor risk patients. Yes, you're on solid grounds for favorable risk patients. Don't do it for patients that have high disease burdens or brain mets. And probably nothing trumps multidisciplinary tumor board here. So the answer to the question is, why are these things changing? We're picking up more tumors and we're just now starting to bend the survival curve. Is probably we've got better systemic therapies. But I suspect that as we integrate surgery into those therapies, and we should, that these curves will continue to bend downward. In Dr. Katie's words, biology for this tumor is king, selection is queen, and the technical maneuvers that we do are the prince and the princess that try to usurp the throne, but are almost always fail to overcome these powerful forces. Thank you very much.